the co-chairs of the Center for Multi-Stakeholder Demonstrations for the PCPCC. I'm so pleased that you all could join us for this webinar. I think it'll be very informative for everyone, and hopefully we'll have lots of questions at the end as well. I want to just say a brief outreach to my fellow co-chairs of the CMD, John Swanson with the AAFP, Julie Shills, who's with Health Teamwork, Sally Bleeks with the Blue Cross Blue Shield Association, and Guy Van Sudo with FITEL. You can outreach to any of us if you have any questions following the webinar, or if you have ideas for future calls or webinars for the Center for Multi-Stakeholder Demonstrations. We'd love to hear from you. So to get started today, a couple of logistics things. The talk is going to last about an hour, and then or maybe a little over, and then we'll have another 25 minutes or so for Q&A. This is a little bit longer than a normal CMD call. Typically these are 1 hour, but we wanted to be sure that we had plenty of time to fit in the speakers and the questions. That's why we extended it by a half an hour today. So we hope you'll be able to join for the whole thing. And in terms of questions, you should have either a chat or a questions bar over on your screen that you can type in a question. And what I will do is keep track of those questions as the moderator of the call, and I'll read out those questions at the end of the call in just the order that I get them, or if there are any that are very much similar questions, I may end up combining a couple of questions. But we'll try to get to all of them, and if we can't for some reason, then I'll certainly be sure that we can follow up with you with regard to your question after the webinar. So with that said, then I'm going to go ahead and do a brief introduction of Marjie Harbrecht, who is with Health Teamworks, which was formerly the Colorado Clinical Guidelines Collaborative. Marjie is the medical/executive director of Health Teamworks, and under her leadership, Health Teamworks, under its name of CCGC, serves as the lead agency for two major national initiatives, Improving Performance in Practice and the Colorado Multi-Payer, Multi-State Patient-Centered Medical Home Pilot, which is what we're going to be hearing about today. So Marjie is going to take on introducing the additional speakers that we'll have on, but just to give you a little bit of a teaser, we're going to be hearing from lots of different perspectives here, from a patient that's engaged in the pilot, from a physician, an ED manager that's working with practices in the pilot, one of the practice coaches, a nurse that's also engaged with the pilot, and one of the health plan representatives from the pilot. So I think we'll get a nice mix of perspectives here, and so please feel free, again, to type in any questions in the question or chat line, and I'll keep track of those so that we can have the panelists answer those questions at the end of the presentation. So with that, the other thing that I want to say, actually, is that this is being recorded. It will be available on the website along with the full bios of the presenters by Friday this week. So, and to find it, what you do is go over to the left-hand navigation bar, and if you go down under resources, there's a link to webinars and podcasts. So you can go there to find this on Friday after this. So if you have to jump out early or miss any of this for any reason, you can catch up on it later on. So with that, I'm going to turn it over to Marjie.
Wonderful. Thanks, Sherry. We've really appreciated having the national societies involved with this at the ACP and the AAFP level, so thank you so much for your support. And I'm very excited to be here today to talk a bit about our one-year anniversary news and really talk about how the pilot has been going, what we've learned a bit, and just share some of the things that we've been doing. As Sherry was saying, Health Teamworks is now, or it was CCGC, or Colorado Clinical Guidelines Collaborative, and so just wanted to say that again. Sherry, this is not working. So we will forward the slides here in a minute. Basically, as Sherry's working on that, of course, as much as you try to plan for all your technical difficulties, they all come up at the last minute. So I'll go ahead and run through the slides, and you can hear me, but you won't see it up on the top. There she goes. Okay, so the Colorado multi-payer, multi-state pilot has involved many, many stakeholders. We have 7 health plans. 5 of them are the national plans, including Aetna, Anthem, WellPoint, Cigna, Humana, and United. We also have 2 of our public plans that have been involved, Colorado Medicaid, as well as Cover Colorado, which is our high-risk pool plan. And that's certainly been an interesting population because it's very different than the commercial population. We have several employer groups at the table, as well as physician societies, as mentioned. Hospitals have been involved with this, and we'll talk a little bit more of how we are engaging them, as well as many others. And we have been working with Cincinnati as a partner region, and the evaluator, who is Meredith Rosenthal from the Harvard School of Public Health, will be evaluating both the Cincinnati as well as the Colorado regions to both compare and contrast some of the findings. She's also evaluating Rhode Island, so there'll be a lot of opportunity to learn from many of the pilots going on. We could not have done this pilot without the Colorado Trust, which has funded Health Teamwork to not only do the coaching and technical assistance, but also to do the convening of the organizations, and then Commonwealth Fund has supported the external evaluation. So to start off with, this could not be possible without our frontline innovators, which are our practices, and there are 17 practice sites and 16 practices. As you can see from this picture, it involves really their whole team, including their front office, back office, physicians, mid-levels. Everybody that's involved with the clinic has become part of this innovation in medical homes, and that's a key part of the learning from all of the work that we're doing, which is really team approach. The pilot parameters, this is now a 3-year pilot. We started off as a 2-year with 1 year of planning, but given how complex, as you could imagine, with all of the payers and the various decisions and design that needed to be put together, there was no roadmap for this pilot. And so really what we've done is kind of take what we can from others doing this work and then customize it or semi-customize it to our environment, which obviously has some complexities because of the number of people and the changing of the systems both at the practice level and the plan levels that have occurred. We started to convene this. The first meeting was in January of 2008, and after several meetings and several discussions, we've basically been talking at least every other week with various groups, including the health plans, and then in between we have meetings as well. So our end date for the pilot will now be May of 2012, and we officially started the pilot in May of 2009. The pilot is based on the medical home joint principles that were agreed upon through the various societies, including family medicine, internal medicine, pediatrics, and the osteopathic medicine groups, and really has also been endorsed by the PCPCC, which is the Patient-Centered Primary Care Collaborative at the national level, who is really pushing medical home pilots across the country. The joint principles essentially include a whole person approach to care with improved quality and safety, making sure that it's a physician-led team, but the team is really the most important piece as well, and that the patient is actually helping the patient navigate through a complex system, particularly when they're sick, but even more importantly to help them stay healthy. And so that really is a lot of the joint principles, and then enabling that work and the transformation of that work through a different payment structure. And I'll talk a little bit more about that in a minute. The practices that participated in this had to go through NCQA Medical Home Recognition Program, which was fairly intensive, and 14 of the sites came in at a level 3, and 2 of the sites are at a level 2. And what that means, if any of you want more information, they're actually in the process right now of revising that recognition program, and so there is an opportunity for you to comment on the program by going to NCQA, and you can actually look at what the new revisions are and put in any comments that you'd like. What we found is that it really gave a great overview of the practices of what were the important pieces of becoming medical home, but that the technical assistance on-site at the practice level, as well as the learning collaboratives where they could all get together and talk about this change and the transformations they were making, was really the most important piece of really transforming the culture and the way that we actually deliver care. As we said, these 17 practices are from family and internal medicine, and they vary in size from solo practice up to our largest practice, which has 15 providers. They go across our front range, so they have some are in a little bit of a smaller area in the southern areas of the front range, and then going all the way up to northern Colorado and Fort Collins area. The patients covered were 20,000 patients that were actually paid for a PMPM or the care management fee, but there will be over 100,000 patients affected through these practices since they are delivering a medical home to everybody in the practice and not just patients that are getting a PMPM fee. However, having said that, there is going to be, with the intensive case management or care management, there will be prioritization to make sure that we handle or work with the patients that are most complex first. So the three-tier payment structure includes a fee-for-service as base, which is basically a normal fee-for-service contract. They did not change at all from the pilot's perspective. What we did add through the pilot was a care management fee, which again is attributed to the practices by a per member per month attribution that every member of that plan in the practice gets an extra fee for that. And then in addition, everybody will get a pay-for-performance bonus for meeting certain criteria for cost, quality, and patient satisfaction. Although there's a lot of discussion of the patient satisfaction and whether to include that in P4P, it was decided that we would be definitely collecting that data at the practice level as well as externally through the evaluator, but it would not be included in the payment structure for P4P. As you can see, there are many pieces of this pilot. We had early on, we formed a physician advisory committee so that it could help set up the design with us. We had a health plan subgroup to help with the payment structure and working through a lot of the details on that. We actually had to develop from scratch a P4P aspect of this because there was no off-the-shelf that was going to work for this pilot. We have a patient advisory committee, which you'll hear a little bit more from Pat Schmidlapp, who is on that, as well as one of the patients in our medical home, and they have been very instrumental in helping us develop patient materials and helping us see things through the patient's eyes. The hospital subgroup, you'll hear a little bit more from one of the practices who's working with one of our hospitals to do a lot. All practices have been working in the past, but starting to help them think differently about not just when the patient is in the office during the visit, but actually what happens before the visit. How do we make sure they get access to the medical homes and the 24/7 ability, as well as what happens after the visit, to making sure that whatever care plan was decided and agreed upon between the patient and the providers, that they all agree on what that care plan needs to look like for the patient, and then start to help them manage through that care plan of whatever needs to be done for preventive care, for chronic disease management, and for if they have an acute problem, how do we make sure that all those things are handled, followed up on, and made sure to get back to the patient to keep them very well in the center of that care plan. For the more complex patients that really need a little bit more help, we have a care plan manager or care coordinator at the practice site to help with that, and also to be the point person for any of the medical neighborhood that is that we need to coordinate with, that the patient would be seeing as part of their care plan, or even outside that care plan, to make sure it all gets coordinated for that patient so they are not fragmented in their care and in their approach to their health. As you can see, there are many people that could be part of the medical neighborhood, even those in the community resources that are not necessarily part of medical, but they could be just part of health and health care. The next piece of this then is looking at how do we prioritize those activities. And again, if you have very complex patients, you want to make sure that they get the more intensive case management or care management. And that right now we are waiting for the health plans to give the practices a list of those patients that need a little bit more help. And the practices are also starting to identify those patients. And then we'll start to work down to making sure they set up a system for everybody, but really, again, making sure that for the complex case management that is prioritized. The goals of the pilot is to improve quality across various measures, including diabetes, cardiovascular disease, tobacco, cessation, depression, and prevention measures. Also to reduce cost trends, primarily by affecting reduction in avoidable emergency room visits and hospital admissions and increasing generic pharmacy. We've also talked about specialist referrals and referrals to high-cost centers. And then, of course, improving satisfaction and experience for patients and their families as well as the healthcare team. We will be doing all of this evaluation both internally to really give feedback to the practices on a very quick basis, as well as externally to be run by Meredith Rosenthal at the Harvard Public School of Health. Just to give you an idea of what the measures and targets are, you can see here that we have for the paper performance measures, which is a subset of all the other measures. You can see here the 9 measures that were selected for P4P, but we also have about 40 other measures that the practices will be looking at, all in those various subjects. And then you can see the P4P targets that we selected, as much as possible using the national targets either from NCQA or other national sources. So just to give you some initial data that we're starting to see in the quality measures, you can see that A1C greater than 9, we want to actually decrease that measure, and our goal is about 5%. You can see that the practices are already starting to reduce that. In addition, the blood pressure and LDL, retinal disease, all the different measures, you can see how they're really starting to increase several of those measures and start to head toward the target goals that we've set. The original number of practices reporting has increased, and as the number of patients increases throughout that, you will start to see some variation in the data where some of the patients coming on will actually reduce the data initially until those patients get under better management. Same with the heart stroke measures. Again, you can see some definite improvements in the measures, although some of them are starting to go down in some places as we add more and more patients. So it really is the opportunity to now dig deep down into that data on a practice-by-practice level to see what systems are working and what needs to be addressed in order to start moving these measures a little bit better, which ultimately translates into better patient care. So that basically gives an overview of the pilot parameters as well as the measures, and I'd like to go ahead and turn this over to one of our patient advocates who has been a tremendous help for us in helping us look through the patient's eyes, not only as a patient in one of our medical home practices, but also as a member of our patient advisory group to help develop our materials and really start to look at things from a different perspective. So, Pat, are you on?
Yes, I am.
Wonderful. I'd like to go ahead and introduce you, and you can start.
Okay. My name's Pat Schmidlapp, and I'm here this afternoon to talk to you about how I became an active member in the PCMH model. So, as a result of that retirement, we left our medical doctors back in Ohio and had to search out for new doctors in this area. Fortunately, we found a doctor here in Parker, and unknowingly, I became a patient in a patient-centered medical home. And it really has been a better experience for me. Over the course of the relationship that I had with my primary care physician, she and I had often discussed health care and changes that were coming down the line and how could we make things better in our own community. And as a result of some of those conversations, one day I offered to help her any way that I could, not knowing where that was going to lead. Surprisingly enough, not long after that, she came to me and said that she was part of a new program that was being utilized here in Colorado and wanted to know if I was interested in becoming a member of the Patient Advisory Committee. And the first thing I said to her was, what in the heck is a patient-centered medical home? Because I had never heard that term before, and the picture that it created in my mind was not what it's really about. But being a member of the Patient Advisory Committee, I've learned to understand what this concept really is and how it's all on my perspective as being a people and every the patients, the one who had attended, the thought occurred to me that maybe there was really something more that I could do. So I went to my physician whether or not she felt there was a need in our community to have a wellness group that could focus on diabetes and caregivers, because I previously was married to a juvenile brittle diabetic, and I was his primary caregiver, and that experience in itself and its primary focus is on chronic illnesses for patients and caregivers. Our focus is to improve knowledge and coping skills, provide a forum to make connections and share success stories, talk about patient responsibilities and how you can be a better patient, and provide helpful resources to the people that attend these meetings. This all started right about the first of the year, and we had our very first meeting the 12th of May, on which we had 9 of her patients participate, and we focused on nutrition. The thing that's important is we could have had our next meeting is going to be held to be discussing at that time exercise and how to fit it into your lifestyle. And I recognize for things she's done with exercise, and she's agreed to come and share those experiences with other people. Not too long ago, I was asked to see if I wanted to participate in another group that is called the Systems of Care Executive Committee, because they wanted to have a patient representative. So I went and I spoke to them, and I have since joined that group. And I really find it very interesting in what they're doing, which complements some of the things the Patient Advisory Committee has done. And I'm looking forward to continuing to work with them in the future. I want to leave you with what I see as a patient, some differences in being in my old doctor's practices and now being a patient in a patient-centered medical home. The first thing that I found that was so extraordinary was the fact that when I first went to see my doctor, everything was electronic. Her nurse used a computer, she used a computer, and they have no paper. Unknowingly, I found out later as a result of a health issue that she's also connected to the hospitals, which allows her to get information much quicker than I'd ever been able to get it from previous care that I'd received back in Ohio. The other thing is significantly different, know exactly where I stand and whether or not we need to set up another appointment, depending on the results. The staff members are genuinely interested in my care and really try to work with me so that I can achieve my goals, which is to maintain the highest level of quality of life possible. We discuss wellness plans, and as a result of a health problem I had over a year ago, we had to collaborate with other resources in order to get me back on my feet again, and they were very open to that. I had not experienced that in the past. The other thing is very nice is when you go in and see your doctor, she's readily informed of what your plan is because it's all electronic, and she's not hunting through stacks and stacks of papers trying to find out when the last tests were run, what the results of those were, and why you're really there to see her, and how can you have a successful meeting. The other thing that I really like very much is the fact that I have access to my own records. So it allows me to go in and see the results of tests that I've had and the progress that I'm making. It helps me to prepare for the next meeting that I'm going to have with her, and it really is very meaningful to know that I'm part of this process. And when they need the care for both the doctor and the patient. You're the fact that able to be part of the patient. Because
our medical neighborhood. So we're aligning with various specialists and different hospital practices. At the practice level, we've focused on a few key areas since last May. and it's been primarily around IT and getting our EMR and our red. Follow through with patients' action plans and making sure that there are systems in place to know when something needs to be done for a patient. And as part of that, we have care plans being set up and care plans being managed by the care coordinators in the practices. Other area that we're focusing on is access to care, so getting the different ways to access our providers or our practices via email, phone calls, e-visits, all those things. So, and then, of course, we're working on embedding evidence-based guidelines while we're doing all these changes at the practice level. So, in terms of technical assistance, as a coach, I really focus on 4 different areas. The top 2 is what I think of basic quality improvements, and that's doing office redesign using the various quality improvement tools such as the chronic care models and the model for improvement, and doing PDSA with our practices. And then we really use the NCQA PCMH recognition tool as a guide to make sure that we check back and make sure that we're aligning with what we think that the different boards of specialties think a patient-centered medical home is, and making sure that we are maximizing our resources in the practices. And then all of our practices submit monthly reports to us. One is based on their clinical measures, and Marjie shared we collect measures on 3 different conditions, and right now it's diabetes, heart stroke, and then we're working on getting depression numbers from our practices. And then we have twice a month we have monthly calls, and I as a coach meet in office with all of the practices twice a month. And then in terms of technology, we don't think any quality improvement work could be done effectively if we're not using registries. So we're making sure that our registry is kept up to date, and we're making sure that we have care plans set up, we have outreach in place, and we know at a practice level that what our population measures look like. And then I already mentioned that we're working on various ways of communicating, and email is an area that most of our practices didn't have in place, and so we're working on that through patient portal and just email communication. And then Cheryl at a system level. All of our practices have their care coordinators hired, and so that makes the communication effective with all of our specialists in our hospitals. In terms of patient-centered care, we're working, it's not a place that you can be an expert at. I think it's something that you constantly have to work on. So we're continuously reassessing our access, we're making sure that the patients understand and that there's shared decision making and that the patient is activated. And so this is just preliminary data for our practices. 94% of our practices have care coordinators in place. We have one practice that is just hiring or actually has offered the position to a care coordinator. So I'm hoping that next time I talk to you guys, it will be at 100%. The registries for heart stroke and diabetes are in place. About 18% of our practices actually have a formal compact being signed with the different specialties that they work with. They're all extending their team roles. I can't think of one practice that hasn't moved outside of the box, and I think every time I talk to them, there's something innovative happening in terms of team roles and who's doing what in the practice. We have 4 practices that did a mini pilot with 4 different hospital systems in trying to get accurate data that they could actually reach out to patients and do something with that data. So we still struggle a little bit about getting timely data from hospitalization and ER, but we're hoping that we will get that data from the health plans within the next couple of weeks to be able to use that data effectively. All of our practices are currently e-prescribing, and so that's an area that we'll constantly monitor. And then in terms of access, about 75% of our practices have extended their hours. Some are working 7 to 7, some are working through lunch, some are staggering their hours so that different providers are coming at different times so that they're able to open their practices beyond the normal 8 to 5 hours. 87% of our practices are effectively using email with patients and specialties, and 100% of our practices now have patients material to be used for our pilot. In terms of provider and staff satisfaction, I don't have data to share with you guys other than I walk into the practice and the vibe that I get when they talk about the work that they're doing is very different than what walking into a practice about 3 or 4 years ago before we started working with these patient-centered medical homes. And I have to say that half of them I've worked with for 3 years, so I can tell the difference in terms of staff and provider satisfaction. So.
Wonderful. Zula, thank you so much. And Zula is kind of the secret sauce that we have. Yeah, she really not only understands the issues that these practices are facing, but can help them kind of navigate through a lot of the complexities that they need to really do to implement the medical home and all the different components of it. I will say that we will be having some spot surveys done by our evaluator from Harvard to assess provider and staff satisfaction. I believe she did some baseline data on that, and we'll be doing some additional data. So we'll be doing that from an external perspective and looking forward to that data. Just also to clarify, Zula says that she's been working with some of these practices for 3 years. That's because we had been doing what we call the Improving Performance in Practice initiative, and that was through a national initiative as well with the primary care societies and boards to help start to get that culture change, team-based care, chronic care model embedment, registry use, et cetera. So it's really kind of the basics that we teach initially as
practices are starting to do that transformation, and then the medical homes are able to start taking them down that journey further and a little bit more intensively outside of their practices to the medical neighborhood. So thank you, Zula, for that insight. The next person I'd like to have share with us is one of our practices, and Dr. Chet Cedars is the physician and manager of the practice called Lone Tree Family Practice, and can talk a little bit about some of the work that they're doing with the hospitals to start to improve that communication, as well as start to think about how do we work with patients to have them come to the medical homes as opposed to just going to the emergency room or hospitals by better management and better access. So, Dr. Cedars?
Thank you, Margie. As you've seen from the previous presenters, one of the big parts of the medical neighborhood is the hospital, and we're fortunate to have a hospital very geographically close to us. We're on their campus, and they've been very helpful in assisting us in getting information regarding visits to the ER or admissions to the hospital. And then we take that information and follow up on it. The two ways they've given us information is, one, there's what they call an autofax that's generated automatically every time a patient is discharged from the emergency department. And that gives us just a very brief amount of information, but basically alerts us that the patient was there, and then we can look deeper into what was done and what reports we need to get on to follow up on with those patients. The other thing that we've done, which is more retroactively, is the medical records department has been able to generate reports for us that we went back 12 months and looked at patients who visited the emergency department over the previous year. And we were able to identify patients that we call frequent flyers or repeat visitors to the emergency department. And we tried to contact these patients and let them know that some of the issues they went to the emergency department for could have been handled in our office. And we are also doing a small survey on the, not retroactively, but going forward, on the patients who we received the notification from the hospital that they've been in the emergency room. We follow up with them by phone to see if they need a follow-up appointment, and also at that time we do a short survey to try to identify why they went to the emergency department. And the preliminary results, these are not official yet, but most of the visits were after office hours, and about 50% of the patients who went to the emergency room were not aware that we had somebody on call 24 hours a day, 7 days a week. And the majority of the ones that did go to the emergency department did not call us prior to going to the emergency department. So that's just a summary of where we stand. Going forward, we've decided that there's incumbent on us to educate our patients that, A, we're available by phone 24 hours a day, even if the office is closed, and that secondly, a lot of visits can be taken care of outside of the emergency department, which saves the patient time and money, saves the health system money, and hopefully is more convenient for everybody involved. And so that's where we are with our little mini pilot project. One last thing. The other issue, which is a big issue for the other practices, but not so much an issue for us, is we do not use hospitals for our inpatient care. We do all that care ourselves. And so the communication on inpatients between the hospital and us is not an issue like it is for many of the practices. Specifically regarding the business, or regarding what, Marty?
Patients are not, that the practices do not in some of the systems that you all have been working on.
My pleasure. This is Cheryl again, and I'm the manager of the emergency department at Skyridge Medical Center, but I've had an opportunity to be involved with this pilot as I completed my graduate work through the University of Colorado. So I was able to coordinate with the executive staff here, and when we rolled out the pilot, we originally presented this topic to most of the key players involved, being the directors of medical records, myself, the emergency department director, our physician relations coordinators, as well as marketing and some other services, just so that everyone was aware of the patient-centered medical home philosophy, and so they understood the direction we were trying to head. And then after that, because this concept can be so high, it seemed like it needed to get down to a lower level where people in their departments really work to implement some of the changes. And so what we found to be most effective was to break this into certain subcommittees so that each area of expertise could work on their own niche and help coordinate the process a little bit better. So initially we've divided this into 4 smaller subcommittees to include the emergency department, medical records, our marketing director, as well as our physician relations coordinators to help coordinate the care between the PCPs and the emergency department. And so all of us have worked to outline our future goals and directions. The emergency department, again, like we've talked about, we want to make sure that the patients, when they get to the emergency department, notify us through the patient-centered medical home wallet card so that we're able to identify them and work to make sure the communication is enhanced between all the players involved. We also have, throughout the Denver market, we've implemented an ED log, which is an electronic database which allows PCPs to notify the emergency department directly of incoming patients, as well as giving us a brief description of what their current chief complaint is and what their past medical history is.
as well as a callback number so that we can real-time notify the PCP's office and let them know what we're finding, as well as get a little bit more history about the patients who are coming in. And then from medical records, we're looking to make sure that, as Dr. Cedars said, that our communication is effective not only from a time perspective to make sure that they're getting timely notifications, but we also want to make sure that the data they're getting is of quality and so that they are given pretty significant information to help them continue to steer these patients in the right direction. And then working with our physicians relations coordinators, we've reached out to all the PCPs who are involved in the pilot to make sure that we're meeting their needs and that they know that Skyridge is here to support them. And for those times when the patient does need the emergency department or our inpatient services, we want to make sure that we have enhanced communication so we're not duplicating tests and we're not miscommunicating, so we're able to have an effective treatment plan for our patients. And I think overall this pilot has been really successful, and it's definitely, you can see the benefits of it. From the administrator's perspective, I can see where it's going to take an entire cultural shift in order to focus not necessarily on illness, but rather health promotion. And if we're asking our patients to maintain a healthy lifestyle, I think the hospitals involved in these pilots need to look at their employees as well to make sure that they're demonstrating health and wellness and possibly even giving incentives to our employees for exercising and smoking cessation programs and things like that. So overall, I think it's all encompassing. It's a really big project, and there's many layers to start to shave away to see where the root of the problem is or where we can work to cut costs and enhance effective care. So it's been a great opportunity to work on this.
Wonderful, Cheryl. Thank you so much and for all the support that you've given. And we're hoping to take what some of the lessons learned are from some of these mini pilots and spread it through the rest of the medical home pilot, and then obviously wider than that as well. So I'd like to go ahead and turn this to Jan Vergo, who is one of the nurses in one of our practices called Westminster Medical Clinic. That's one of the medical home practices, and talk a bit about some of the care coordination with the specialists in the medical neighborhood. So Jan?
Well, thank you. I've been with our practice for 21 years and have seen a tremendous amount of change, particularly in the last couple of years, and it's been very heartwarming. Our medical neighborhood that we have been working on for several months now, we have on board about 25 plus specialists, and actually we're calling the compact more of a collaborative guidelines. Of the 25 physicians, we have 3 large offices, and the rest are smaller or single practice offices. And our process has been to use a personal touch by having small meetings with 2 to 4 practices at a time at our office. And we're working on building camaraderie, rapport, and fostering some relationships among the specialists who are joining the neighborhood. Our program manager, Caitlin, she sets up these meetings. We've sent out letters and invited these specialists. And after they have been to our first meeting and had the compact explained by Dr. Hammond, Caitlin sets up a second meeting with the specialty office to help them implement many of the things that are in the guidelines or compact. And that's after they've looked over everything and check off the boxes that they can and are willing to do. And then we do, the part we're working on currently is some evaluations with report cards and some chart audits, particularly in our office, making sure that we're sending the information that we have agreed to do to the specialist. And so that's one of our chart audits, is making sure that what we want to send to them is needed what they need that they get. And we're also working on some patient satisfaction surveys. I think we've created like 3 or 4 questions to call the patient up after they have been to the specialist to see how their experience was, like how long their wait was, did they get their care plan, did they understand their care plan, and how their office staff, actually they were treated by the office staff. That is coming up where we've got to get those questions concreted and the patients to call. So that is our project for next week, I believe. And so we're working pretty diligently to work on our piece of the compact, and the medical neighborhood we're pretty excited about, and the specialists seem quite excited about it too. So, and one of the things I wanted to talk about was our access with St. Anthony's systems. It has worked out very well for us to access St. Anthony's systems, and the patients who are associated with us to get their information quickly as they are discharged from the hospital. And it has worked very well for us to access that, get their discharge summary. Care coordination piece that we do is making sure that the patient comes back and see us quickly within 48 to 72 hours after they're discharged from the hospital or the SNF. So care coordination is a big part of my piece of the patient-centered medical home, which has been quite fun and challenging for me. So I think that's about all I've got. And any questions, I'll be happy to answer.
Wonderful, Jan. Thank you so much. And we have one more speaker before we open for question and answer, so please hold your questions, but all of our speakers will be available for that. And Jan is one of the other mini pilots that we're doing with the hospitals, so they are testing a few different things. And in the true sense of quality improvement, we started with a couple what we call PDSA cycles just to start to test some of these, and then be able to hopefully spread that to other practices and hospitals as they start to work on some of those systems. So, Jan, thank you so much. You're doing some great work, as well as Dr. Cedars and Cheryl, so thank you. Our last speaker is Dr. Chris Stanley, and Chris has been, he's one of the medical directors of the United Health Plan, United Healthcare, and can bring the perspective of how does this look from a health plan. So, Chris, are you available?
Yes, I am. Margie, let me just confirm that you can hear me okay?
We can. Maybe a little bit louder would be great.
Okay, thanks. I'll talk just a little bit louder. Thanks very much for the opportunity. Again, as Margie mentioned, my name is Dr. Chris Stanley. I'm the Senior Medical Director with United Healthcare in Colorado. And while I have the pleasure this afternoon to give you just a few-minute glimpse of where health plans, or where at least United Healthcare sees the patient-centered medical home value here in the state of Colorado, really this is representative for all of the health plans, even beyond just United Healthcare. So I want to give the listeners just a bit of a sense for health plans. For most of the health plans that are involved in this particular initiative, this is not only a really exciting time, but we see Colorado as being one of the most advanced and truly clinically integrated pilots for what we see across the United States. United Healthcare, for example, is involved in on the ground 4 different pilots across the U.S. in various states. And Colorado, again, is by far the most advanced and integrated, partly related to health teamwork's participation. Great kudos to physicians and the hospitals in the state as well. So I want to focus in particular about 4 different capabilities or expanded clinical services that health plans and United Healthcare specifically see, where we think that there's significant value to the system out of PCMH. One is enhanced access by having extended hours in some practices, having weekend hours in other practices, having after-hours support, as Dr. Cedars I was mentioning with being able to connect with patients, with their particular patients, to keep them out of the emergency room, we think there's very significant value there. Secondly, is really that care coordination component, which again, most primary care physicians, including myself, feel like we try to do on an ongoing basis anyway, and we've always been trained to do that. The challenge has been that the healthcare system is relatively very fractionated, and it's quite difficult to be able to coordinate across the entire continuum from inpatient to outpatient, ER, pharmacy, specialist, and primary care. And we're really setting up through this model, and what we're seeing playing out is that care coordination. Team care is really a cultural mindset that again, I would give great kudos to all of the sites and to Health Teamworks for facilitating here in Colorado. Without that mindset difference, without the team care-based care, none of this really could be achievable at all. And then what's really going to be important, not only for United, but for other health plans, and frankly should be important as well for all physicians and participants, is looking at where are we making improvement? What are the metrics? What are the quality of care? What's the cost of care? What's the satisfaction the satisfaction for physicians and for patients and for staff, to say, are we fundamentally making a difference, or are we really just trying to sort of tweak on the margin? Clinical information systems are really important for that to be integrated as well, and where we see health plans participating and helping to facilitate as well is through the use of certain technology and tools that the health plans may have, and most of the time do have the resources for or the data for, but we've not necessarily had a great connectivity back to the primary care physician to make it particularly actionable. So that's where health plans can bring that information now to physicians, and working through this type of a pilot, we're now actually seeing that it's truly making a difference, and care is being delivered in a different way. And then lastly is, I'll just mention real quickly about transformation support. It is so fundamentally critical that that support is there, whether it is provided by a health plan, which may not necessarily be the best way or the best location for that to be provided for primary care offices, or whether it's through an organization like Health Teamworks that has the boots on the ground, has gone through it before, knows exactly what it's like to be in the trenches with a primary care physician, to say, here's how care can be delivered differently, not extra work, but in fact more efficient work and better work, leading directly to improved quality of care. So again, we as a health plan really see significant value in this. Each patient population is going to be unique and different as far as where's the dollars come from, what's the amount of dollars, how did the dollars flow, and I guess I would say that in all of our pilots that we're involved with across the U.S., each one of those is uniquely different. It needs to be tailored for that particular geography and that particular community. But the commonalities are those things like the access, care coordination, and team-based care. I think I'll probably stop my comments at this point just for some time for question and answer. So, Marjie, I'll pass it back to you.
Thank you so much, Chris, and it's been a pleasure working with you through this pilot, and really starting to think how we can bring everybody together to think through these complex issues, both from a health plan, practice, and employer standpoint. So that's been very helpful. So before I turn this back over to Sherry, I just want to basically summarize very quickly that I hope you've heard through this that this is really much past just a kind of a recognition or a check the box of some kind, that it really is an embedding of systems and a culture change to really thinking about how we deliver care differently and how we pay for that care differently. And both of those things are going to be very important as we move forward in being able to actually defragment our currently siloed healthcare system and get back to the very important relationship that this is all based on, which is the relationship between the patient and the provider, the patient and their healthcare team, and everybody with the medical neighborhood and working together. So with that, Sherry, I'd like to turn it back over to you for question and answer.
Great. Thank you, Marjie. This is Sherry Erickson, one of the co-chairs of the Center for Multi-Stakeholder Demonstrations. And in case we run out of time, I just want to say a huge thank you to all of you who presented today. I found it very informative, and I hope everybody else did too. I'm gathering they did because we have a lot of questions lined up. which I'm going to try to work through as quickly or efficiently as we can while still covering the content. As a reminder, because this was a question that we got a few times, the webinar is being recorded and will be available on the PCPCC website by Friday. The way you can access it is to go to the left-hand navigation bar, scroll down, and you'll see a resources section, and under that there's webinars and podcasts. You can go there. The bios and the slides will also be available. So with that, I'm going to start off with some questions that were sent in throughout the presentation, and I'm going to try to just go through them in order, and hopefully we can get through them all. So I'm going to ask the speakers to be as provide as much information as you can in as concise a manner as possible so we can try to get through them. But if we can't, I appreciate, Margie, that you put your contact information up there so people can do outreach if they're not able to get to all the questions. So with that, great. One of the first questions, and this was something I know you all have incorporated in your pilot but haven't talked about, but didn't really speak to a lot right now, and that is the question generally was, could somebody briefly summarize financially viable models for embedded medical or mental health providers in the PCMH, or post some resources that summarize or highlight successful models? And I know you don't have time to talk about that in depth, but if you could just maybe touch on what you have done in terms of incorporating mental and behavioral health into the pilot.
Sure, I can take that one. Basically, we are just at the beginning of that. We have hired someone who is an expert in mental and behavioral health to work with us, and we had an advisory committee to look at this. And what we've, and that included, by the way, Gary Oxidal and his team from the Diamond model in Minnesota. But basically what we've looked at is how do we, number one, what is the most important thing to start looking at both the mental health aspects and the behavioral health aspects, which is the lifestyle changes and all the behavior changes that need to happen for our patients as we engage them in this new journey. And so we had three basic premises that we were going to work on. One is that this care coordination or care manager at the practice level is a very unique and different position than has happened before. So the first thing is we need to train them for all the functionalities that we're talking to them to deliver, which is not only that care plan manager of, tracking labs and tracking referrals, et cetera, but really helping enable and engage the patient in their care, doing some self-management support, and working with the rest of the team to do that. The second piece of that then was to talk about the potential for hiring a shared service of, actually getting either a psychiatrist and or a psychiatric nurse or some type of resources that could be shared among the practices that otherwise were not big enough to really hire someone on site. And we do have a couple practices that have hired some folks on site. And I would say the model is, that's probably a break-even is what we're hearing, although for some practices where they're just renting out some space with some mental health providers, then that seems to be working out okay. So I don't have time to go into a lot of details, but we're looking at kind of a shared cohabitated or co-located model versus a shared resource model versus just a referral model, and then building those bridges with better bidirectional communication and information, just like at the hospital, so that we're not doing the 1-800 black box, I don't get to see or hear about the patient once I refer them. So those are the biggest issues we're working on.
Great. Thank you, Margie. And so one thing I wanted to mention as well is that the PCPCC does have a task force on behavioral health that people can become engaged in. And I know one of the things that they're hoping to do is to learn more about what pilots are doing with regard to integrating mental and behavioral health into the pilot. So hopefully as they continue their work, we'll be able to build more information about that on the PCPCC side as well. So thank you, Margie.
Sure.
Next question is related to NCQA changes. And so I guess stepping back, the question is, what would you say the three most important quality measures are related to NCQA recognition, and how might that better inform NCQA's revision process? I hope I got that correct.
I'll have Zula start with that, and then I can add in as well.
Okay, great. Thanks.
Can I just ask a clarifying question? When you say quality measures in terms of just
basic QI or clinical quality?
Well, I don't know, but I will say the next question by the same participant was asking whether you were only looking at process measures for P4P or if there were any clinical outcomes. So I don't know if that helps inform that first question at all.
Yeah, so we're actually doing, for the P4P, we're focusing majority of our measures around outcome, and then, but at the same time we're tracking process, mainly because we don't feel like we need to know where we've started and where we're heading, and we just needed to make sure that we knew our population at overall before so we needed to focus on our process measures first, but in terms of the P4P measures, we're doing a lot on outcomes. So we're focused on cost trends, and then we're also focusing on clinical measures, and Carrie has the slide up in terms of our clinical measures that are actually both our clinical and cost measures that we're tracking for P4P.
Well, thanks. And I guess the question maybe is more along the lines of, based on what you've seen so far from these measures that you've been using, does that provide, how would you use what you've learned to provide feedback to NCQA on their revision process?
So I can talk to that. I'm actually on the NCQA task force to help revise this. And I think some of the initial things that came out, first of all, it's a fairly complex tool, and they've done an amazing job. And we think it's really important, especially given 7 health plans and all the practices. How would you say I am a medical home if you don't have some kind of standardized way to assess that? So we think that's a really important thing. Having said that, it was hard to, really put all the pieces together, and I think they did a great job in the start. Now it's just a question of refining that. I think one of the issues that came out was, that it needs to be a little bit more patient-centered, that there needs to be more things that would actually come from a patient side that would be attached to the mental health integration and behavioral health integration. I think is also going to be embedded a little bit better. And again, there are certain things, the access issues, the relationship issues, all of those different things that we talked about through this talk today, that you can at least start with to get an idea of what are my systems in place, how do I look at things initially, but then you really need that as a way to dig down deeper and start to really figure out what I can do to start to move that needle. And now, if the question is more on a clinical measures perspective, I think you could almost select whatever content you want once you have the solid infrastructure built in the practice of team-based care, coordination of care, communication with the patients and engagement with the patients. Once you have a lot of the things that come right out of the chronic care or planned care model, then the content issues like diabetes or asthma or COPD or congestive heart failure or other things it probably does not make a tremendous amount of difference. We tried to pick a gamut of things that were fairly common that would be relatively easy to implement. We were going to do low back pain, which we thought would be an ROI measure, for return on investment, but it was very complex to add that on top of everything else. So we have since decided not to do that. But I think the content issues, once you have your solid infrastructure, is not as important. But I would strongly suggest adding prevention in there of some kind. And these measures that you saw before are just year one. We'll probably be adding some for the pay for performance for year two.
Great. Thank you, Margie. Another related question was someone was asking for a little bit more detail on how your P4P component works. And I know that's probably a lot to go into, but if you want to give just a brief summary, and then if there's any sort of materials or other information you could provide on it that we could include on the website, then that would be helpful as well.
Sure. So I'll go back to the measures just so you can see them. But Basically, there were two major components of the P for P, the quality and the cost trend. And as I said before, we decided, even though it was the really important piece of the pilot, was not to add the patient survey piece into it, although every practice is doing it. We just got baseline data from practices where they had to sample 200 patients over a 6-week period, and we gave them a tool to do that. What we found was that because, and we were told by many people across the country that it just probably is not accurate enough for you to tie it to P for P. So that's why we said we'll do it and we'll tie it to redesign and quality improvement, but not for the payment piece. So the payment was really based on whether the practices individually for the quality measures would be able to move and meet the target goals, as you see on the screen, and also and they need to meet, and the goals that we set here are a bit higher than what we actually have for the P for P, if you'll notice that. But we took the P for P measures right out of NCQA in general. But the idea is to say if they meet that as a practice, then they will get, if they meet 100%, they get 100% of the dollars for quality. And if they don't meet 100%, then they'll get a portion of the dollars. And 60% of the total dollars go to quality. 40% of the other 40% of the dollars go to cost trends. And because we did not feel that each practice individually had enough volume to contribute to the cost trends, we and the plans all decided that we would have that as an aggregated measure across the entire pilot, so across all 17 practice sites. So that data would be looked at as and aggregated to be able to meet these cost trend measures. And then the practices will be paid individually according to their attribution, depending on how that cost looks.
Great. Thank you, Margie. And I want to just recognize the time. We have only about 1 or 2 minutes left in our official scheduled time. But I wanted to get through maybe at least a couple more questions for the recording purposes, and then we can follow up by email, if that's okay with you, Margie, and maybe some of the other presenters. It may run us over about 5 minutes or so, maybe a little bit longer, just to try to get through a few more of the questions so that people who are accessing this on the recording would be able to listen through for some additional questions. Is that okay?
That's fine with us.
Okay.
And what I would say is if you do have some additional questions, if you could send them to Carrie, and then she could kind of collate all the answers and get them back to you.
Great. So we'll just do maybe 1 or 2 here, and then we'll wrap up. One is there a common patient satisfaction evaluation tool which your collaborative practices are utilizing? Are the practices paying for it, or is the collaborative paying for the survey?
This is Carrie. We did create a consistent survey that all the practices use. We really based the survey off of the How's Your Health and just shortened it up to a one-pager that we felt that patients would have the time and take the time to fill out. We made it available to the practices in 2 ways. We made it available via paper that they could just make copies and hand out. And then we also made it available through SurveyMonkey. We had a smaller number of practices utilize the SurveyMonkey tool than we had anticipated. Most used the paper survey. The University of Colorado School of Pharmacy is actually working on the data analysis, and they are doing it for us at this time at no cost. So there really isn't a cost to the practices or the pilot. However, they have found that inputting 200 paper surveys across 16 practices to be quite lengthy, so we have to reevaluate for our next survey. We're surveying the practices every 6 months. And the practices were hugely compliant in completing their 200 surveys, which is what we were given as a statistically significant number.
Great,
so
thank you. Oh, sorry, go ahead.
I was going to throw in, one of the things that Zula will be doing with that data is actually using it, like the quality data, to feed that information back to the practices to actually see what things they can change in their processes to address any issues that come up. So it's a very important thing to embed in any measure that you're trying to move, is to have data at baseline and then throughout so that you can really start to see what changes need to be made to address the areas that you're having issues with.
Great. Thank you, both Carrie and Margie. The next question, and I'm going to actually ask sort of two questions together. And one is, do you have a sample specialist compact to distribute? And as part of that question, what was the hardest part for specialists to accept? And then the other related question I wanted to ask was just a general question of whether the presenters will be willing to share the tools that they have referenced in their presentation.
So, Jan, do you want to take that a little bit? I know that's being worked on by Dr. Hammond and through the Systems of Care grant.
Yeah, we do have. Yes, we do have a sample of it. I don't have one currently in front of me, but it came from the Colorado Academy of Family Physicians, I believe, the original one, and he has just sort of adapted it a little bit, changing a little bit of the wording to suit our practice as well as the specialist practice. And what was the other half of the question?
The other part of that question was, what was the hardest part for specialists to accept?
I think there were pieces of it that each specialist had, and it's just actually check boxes that, yes, I can do this, yes, I can do that, no, we don't have that availability. So they can say yes or no to different pieces of it. So I don't think there was anything specific that was a difficulty for any specialist. It was like, no, I don't have that availability. I mean, I don't think there was anything specific that they had an issue with, other than if they were not able to do that, then they just didn't check that box.
Great, thank you. Yeah, go ahead, Margie.
This is Zula. Having worked with some of the practices that have tried to use the compact, I think some of the things that I've seen in terms of challenges that we faced was that even though the compact is a lot of check boxes and coming to an agreement on what each practice will provide, I think initially on the first couple of meetings it was the specialist kind of felt that the primary care physician was asking them to check all the boxes versus, that you can skip some of the boxes and you don't really have to address all those things, but it was more of we need to have an understanding of what it is, what your capabilities are and what our capabilities are, and understanding, working towards a common goal so that they could address those areas that they felt were lacking either on the primary care end of things or the specialist end of things. Was there anything, this is Carrie, was there any particular components that many specialists have a hard time agreeing to, such as, immediate communication or sharing of files back and forth or anything like that that they felt like the primary care physician was trying to dictate to them how they would practice medicine? Was there any of that?
I think the one that I saw the most resistance towards was first visit had to be with an MD versus a mid-level. I think I saw a little bit of pushback on that one, and I think that that's the one that most practices have, most primary cares have just let go of, and I think it had a lot to do with accessing care. And so if you were just trying to see an MD versus a mid-level, the amount of time seeing a provider within that specialist group was being extended out. So I think that that's the one that I saw pushback on. And just a last comment, just to clarify, the tool was based, I believe, on a couple different tools, but one was the ACP tool that was developed, and it is now being worked on through the Colorado Medical Society here, where we have several of us working together to help work on the culture change that has to occur to start getting people to talk to each other again. I mean, I think that used to happen in the old days, but I think that we've really become a lot more siloed. So this is really an opportunity to bring people back to starting to have that conversation. You know, when we used to all go to the hospital, we could hang out in the, you know, doc lounge and kind of do on-site consults there, or at least, you know, kind of drive-by consults. And I think some of that has really changed with a lot of the segregation of not really having a common place to come. So what we've heard for the primary care docs is it's really a lot of work for them to go out one by one to their specialists to try to get them engaged in this. And so that's something that we're working on to see how could we do this in a more streamlined approach.
Great. Thanks to all of you. And there are a number of really excellent questions that we have here on hand that unfortunately we aren't going to have time to get to on this webinar. These questions will be saved, so we have the question and the name of the person who asked the question, and we can send those on to the folks with Health Teamworks to help answer those questions. However, not entirely sure that your email address is always captured with these questions. So just in case, it wouldn't hurt if your question was not answered on this call, if you could send an email, as Margie mentioned, to Carrie Loken with Health Teamworks, and her email address is here on the screen, then she can be sure that your question gets to the most appropriate person. So that way we'll be sure we get it one way or another. So with that, this is Sherry Erickson again, one of the co-chairs of the CMD, and I really want to thank all of our speakers. It was an excellent presentation. A lot of information, and I know a lot more that people would like to learn about the project. So hopefully we can continue to share information and maybe do another update next year, and you can tell us more about what's going on. So appreciate the opportunity to have you all on, and appreciate everybody else for participating and hanging in there with us. I know we ran a little bit over time, so I appreciate that, everyone. Thank you.
Thank you. Bye-bye.